Hi friends, I'm Dr. Mayur Kulkarni, your radiology faculty, and let us quickly jump into the recall discussion session for all the radiology and related questions which were asked in this recent NEET-PG 2024 exam. Before we jump right into the questions, I want you to be introduced to a term which is called as second order thinking. Have you heard of it? What does it mean? Well, when you encounter a particular situation, say a circumstance, right, or a person, right, the first thing that you do is you react to it. That is what is called as the first order thinking. The first order thinking, remember, is relatively simple. It is more superficial and it is more like a reaction that you give to a particular situation or an experience. What is really important, and I want you to do, is what is called as second order thinking. Well, it was Sir Howard Marks who introduced this term of second order thinking. Second order thinking goes much beyond what your initial reaction was. So it is much more deep, it is much more deliberate, right? And it is not just about your reaction, but beyond that you start you start considering what could be the consequences, the first line, second line consequence. You start to think about ways to go about managing a particular situation, right? And this is what gives you in the long run a significant competitive edge over others. Now, for example, suppose let us consider this particular NEET-PG exam. Well, the first way to the first, an example of first order thinking to react to it was to say that the exam was moderately difficult, right? You got these many right, these many wrong, you did some silly mistakes, and you wish you could have done better in this particular exam. Almost everybody feels so. Well, this is just an example of first order thinking as far as this NEET-PG exam is concerned. But then, if you think about it more carefully, you do not just think about the type of questions, right, and what topics were asked. You start to realize what were the specific trends in this particular exam, right? What were the range of topics which were asked? Were they repeated topics? Were there new topic questions? What was the type or pattern of questions, right, which was asked? And then even going beyond that, you use all of this to in fact strengthen your preparation for the upcoming exams, so that by the time you get to these upcoming exams, right, you have already thought this through, you have gone through all these trends, you have analyzed it, and you are at a much better position than what you are right now. And this is the very purpose of getting into all these recall sessions or discussions, right? So I'll give you a perfect example of how we can use all these things, apply a little bit of second order thinking, and get better with time as we prepare for your upcoming exams. So on this note of second order thinking, let us jump into the first question that we're going to discuss. So these are the first session questions that we are discussing. This is the radiograph of a child with a foreign body in the esophagus. So the examiner has told you where the foreign body is. It is in the esophagus, right? What is the sign seen in this? Is it steeple sign, like the top of the church, the subglottic airway, getting narrowed, the elongated narrowing there, which is seen in crow, or acute laryngotracheobronchitis? No, definitely it is not. Is it the thumb sign, which is seen in acute epiglottitis because of the thickening of the epiglottis? No, it is not. Is it string sign or narrowing? This is mainly seen related to the bowel, right? So it is seen in achalasia, it is seen in hypertrophic pyloric stenosis, tuberculosis of the bowel. No, it is not. Here you are able to see a prominent foreign body there, and this foreign body is giving rise to a very peculiar appearance. What is that appearance? Now, before we get there, let us quickly revise. This is something that we've already discussed. A foreign body within the esophagus, so this is an esophageal foreign body, will lie in the coronal plane, so you will see it end on, and that is how it is looking at like on this particular radiograph. Whereas a foreign body in the trachea, because it has to first pass through the glottic opening, right? The glottic opening in my body is guarded by these two vocal cords. So a foreign body like a coin has to pass through these vocal cords. It will have to pass through it in the sagittal plane. As it goes into the trachea, right, it will be held in the sagittal plane by the tracheal cartilaginous rings. So it will appear from the side. You'll see it from the side and not face, right, face on or head on. So this is a foreign body within the trachea. So this is something that is sorted. The examiner told you that this is a foreign body within the esophagus? Is it a coin or is it a button battery? If you look at this opacity carefully, now do you see there are two rings which are seen? Well, one of those rings is this inner ring. Can you see that? Yes, so this is one ring, and the other ring that you see is the outer ring. So what is this sign called as? So this sign is what is called as, yes, the double ring sign, or this is also called as the halo sign. So double ring sign or halo sign. And if you look at this foreign body, what is this? This is nothing but a button battery. Why is it so? Because a button battery is actually made up of two electrodes. One of the electrode is a smaller disc, the other electrode is a slightly bigger disc, and that is why this appearance is created. If you look at it from the side, right, you can see another sign. Because there are two rings, remember, this is the larger ring here, and when you look at the front, there is a smaller ring like this, and this appearance is what is called as the step of sign. So what are the signs that we are seeing in case of a button battery lodged within the esophagus? From the front, you're able to see the double ring sign or halo sign. From the sides, you're able to see a step of sign. Why is it so? Because I just told you there are two electrodes, there are two rings. What are those two rings? Let us learn something extra here. Let us get that extra charge from this button battery discussion here. So there are two electrodes, anode and cathode. The smaller disc, remember, is the anode, whereas the larger disc is the cathode. Why is it necessary for us to know this? Is because which of these is more damaging? Clinically, remember, when you manage these patients, I want you to know that it is this anode part, that is the smaller ring, which is considered to be more damaging. And therefore, the part of the esophageal wall which is in contact with the anode disc is going to be more prone to injury, right? So therefore, it will lead to complications. If this anode ring faces anteriorly, it opposes the anterior esophageal wall, then there is a risk of development of a complication which is called as the tracheoesophageal fistulas. Whereas if this anode ring faces posteriorly, it is in contact with the posterior esophageal wall, then there is a possibility of development of esophageal aortic communications or fistulas. It could also lead to development of discitis involving the thoracic intervertebral discs, right? And therefore, how do you manage it? You do an esophagoscopy, remove the button battery which is lodged. While you remove it, you inspect the mucosa, you see, visualize the mucosa, look for damage, and if there is an evidence of damage, you want to rule out the extension of damage to the surrounding organs, right? It could be the aorta, it could be the trachea, it could be the disc. So next, you can try and do a CT or an MR or NCT angiography to look for further complications beyond the esophagus. So this is a little bit of extra edge that I wanted you to know, extra charge that we have obtained from this particular button battery related discussion. So what is the sign which is seen here in this particular radiograph? The sign which is seen here in this radiograph is the double ring sign. So that is going to be the answer to this particular question. This was a repeat from a recent INI set pattern question, which was a similar one which was asked. Let's look at the next question now. The patient complains of severe headache. A non-contrast and CT angiography images are given below. What is the likely etiology? So if you look at this non-contrast CT image, what you see is a star-shaped hyperdensity, which is there because of there being acute blood within the basal cistern. So blood within the basal cisterns gives you a diagnosis of subarachnoid hemorrhage. This is also sometimes called as the star of death. And why is there subarachnoid hemorrhage? Is because what is the most common cause of such subarachnoid hemorrhage, right? A star-shaped hyperdensity is because rupture of a peri-aneurysm. So this is a CT angiography image where you are able to see a large aneurysm which is involving the left internal carotid artery. So left internal carotid artery. So what is the answer to this question? It is a subarachnoid hemorrhage due to a peri-aneurysm rupture. Let us quickly explore a few things about this particular diagnosis. Remember, we've already discussed this in our main videos. This is a history clincher, clinical clincher, middle-aged patient, typically The word used is thunderclap. It was not used in this particular question, but definitely there was a history of headache. So thunderclap headache or worst headache of life is a very typical history which is given. Patient is unconscious, altered sensorium. You see a star-shaped hyperdensity because of subarachnoid hemorrhage within the basal cisterns. The cause is what? The cause is rupture of berry aneurysms. The patient presents with subarachnoid hemorrhage, we know that the most common, or a lot of blood within the basal cisterns, we know that the most common cause is going to be rupture of berry aneurysms. So what do we do for further imaging? What we usually do is CT angiography, right? So that is what we have done here, and we were able to see this big, right, aneurysm, saccular aneurysm coming from the left internal carotid artery. Well, if the examiner asks you in your upcoming exam for subarachnoid hemorrhage, the investigation of choice, remember, is usually non-contrast. CT as the initial investigation which will establish the diagnosis. However, remember, occasionally in subacute SH or chronic SH, CT might not help you to pick up this hemorrhage very well, and only in such selective cases an MRI may occasionally be done. But for acute SH, CT, time is of essence here for a diagnosis. CT is the investigation of choice. Well, if your examiner asks you for berry aneurysms, so berry aneurysms are small outpouchings along the walls of the circle of Willis. The most common site of berry aneurysm is, remember, along the anterior communicating artery. So anterior communicating artery, right, is the most common site for a berry aneurysm. So for berry aneurysm diagnosis, the investigation of choice that we usually use is a CT angiography. MR angio is used in only a few specific cases where contrast cannot be injected. The gold standard, remember, for any vascular abnormality remains invasive angiography. And for the brain and intracranial vessels, we do a invasive angiogram, which is called digital subtraction angiography. So this is all you need to know about the imaging of SAH and berry aneurysms. So we come back to this question. Patient presents with severe headache. Remember the term thunderclap headache, worst headache of life, non-contrast. CT and CT angio shows the star-like hyperdensity of blood within the basal cisterns and an aneurysm. So what is this? It is subarachnoid hemorrhage due to berry aneurysm rupture. So that is going to be the answer to this particular question. Pretty straightforward. It has also been asked before in a few of your exams. This is very typical. This is a clinical clincher again. See, a lot of clinical clinchers were asked in this particular exam. A 6-week-old neonate was brought with complaints of recurrent vomiting. So this age is a clue. 6-week-old neonate. USG was done and is shown here. So what is the diagnosis? Let us quickly have a look at a clinical based approach that we have already discussed. Child presents with vomiting. If the child presents at birth, immediately at birth, with bilious vomiting, it means that a particular part of the bowel is atretic, it has not formed, and that is the reason why the child is presenting immediately at birth. And which part is not formed? It is usually the distal duodenum beyond the second part, which has not developed. So the biliary tree opens into the duodenum, but the bile cannot pass distally, so the child simply vomits it out. Therefore, the child has bilious vomiting, and hence the diagnosis you must consider in this particular clinical scenario is what? It is, yes, duodenal atresia, correct? But in this particular question in your exam, it was not presenting at birth. It presents a few weeks later, so about 6 to 12 weeks of age. Why? Because it is not present at birth. This hypertrophy of the pyloric region, oh, spoiler alert, I gave away the diagnosis for you here, develops after a few weeks, right? And because the biliary tree is opening into the second part of the duodenum, the bile can pass distally, but whatever is the content within the stomach is vomited out. Therefore, the child has non-bilious vomiting, and hence, in this case, the diagnosis you must be considering is hypertrophic, correct? Is hypertrophic pyloric stenosis, correct? So that is how these are two different clinical clinchers. They have been asked multiple times. So a neonate presents with bilious vomiting antenatally, right? On USG, you could see two bubbles. Postnatally, right? Typical clinical clincher we have seen. Again, you see two bubbles. First bubble is the stomach. Second bubble is the proximal duodenum. Look at the two bubbles highlighted for you with magic view graphics here. And what is your diagnosis? Your diagnosis here, as we've discussed, is going to be duodenal atresia. So what is this sign called as? This sign is what is called as your double bubble sign. So double bubble sign, which is seen in duodenal atresia, where occasionally few bubble signs have been described. A single bubble sign is described in hypertrophic pyloric stenosis, whereas a triple bubble sign has been described in jejunal atresias. Yes, so triple bubble sign has been described in jejunal atresia. So this is the clinical clincher of duodenal atresia. Now, this is what was asked: 6 weeks old infant, projectile non-bilious vomiting, olive-shaped mass, typically a male child, olive-shaped mass which is felt over the epigastrium, right? And a barium meal study was done in the olden days. Look at the graphics there. It is showing you the narrowing of the pyloric canal. Why? Because there was this hypertrophied muscle there. On a barium meal study, various signs have been described, right? The stomach hypercontracting to push the barium across. This is what is called as the caterpillar sign. Various signs have been described on barium meal study, right? So this hypertrophic pyloric muscle over here creates an impression on the distal stomach like a shoulder. So this is what is called as the shoulder sign. The opening at the pylorus is elongated, narrow like a beak. This is called as the beak sign. The pyloric canal is extremely narrow. This is what is called as a string sign. And the shape of the duodenum you can see here is like a mushroom. So this is what is called as a mushroom sign. So these are all the signs which have been described on a barium meal study in a case of pyloric stenosis. What is the investigation of choice though? This was something which was shown in your exam. So investigation of choice is USG. Why? Because the pylorus is superficial. It can very well be visualized, has no radiation exposure to the child, can be done very comfortably at the bedside while the child is being fed, right? You can have a look at the pyloric canal. So the pyloric muscle, length of the pyloric canal more than 16 millimeters, and the thickness of the pyloric muscle layer more than 4 millimeters is usually considered to be a criterion to make a diagnosis of hypertrophy of the pyloric muscle. Okay, so this is all that you need to know about hypertrophic pyloric stenosis. This is what we have discussed here. Yes, now one of the options in your exams was also mid-gut volvulus. What is mid-gut volvulus? It is nothing but a malrotation anomaly of the bowel, where because of a short mesentery, right, it is the distal duodenum and the proximal jejunum which twists over the superior mesenteric artery. So the duodenum and the jejunum goes round and round around the right superior mesenteric artery, and this creates on barium studies and on CT scans it is seen. This is what gives rise to the whirlpool appearance. So what is this condition? So this is whirlpool appearance, right? This are what are features of mid-gut volvulus. Right, mid-gut volvulus is a malrotation anomaly. It is because of a short base of the mesentery, the bowel gets twisted or torsed. It is the distal duodenum and the jejunum which twists around the superior mesenteric artery, creating a whirlpool appearance. This was one of the options. So if you see here, you can see on USG, this is the stomach, right? This is the thick pyloric canal. Can you see the thickness they have measured there? So a length of more than 16 millimeters and a thickness of more than 4 millimeters clinches the diagnosis. We are actually looking at the pyloric muscle which is hypertrophied there, and hence the answer here is hypertrophic pyloric stenosis. Duodenal atresia, annular pancreas, both of them will present with bilious vomiting, double bowel signs. Midgut volvulus, whirlpool sign is what we just saw. So this is about pyloric stenosis. Yes. So this was a classic application-based question. See, young patient presents with nasal polyps, rhinosinusitis, X-ray and clinical images as shown below. What is the diagnosis? Let us look at the findings one by one. Actually, we have discussed this in the mainstem videos here. Look at this clinical scenario. 22-year-old male undergoes a chest X-ray PAV for pre-employment checkup. Based on this finding, we have discussed this patient may have a propensity to develop what? Now, what is this finding here? Look at the chest X-ray carefully. This is the right side. This will be the left side. The heart should normally be present on the left side. It is not present here. Where is the heart? The heart is pointing to the right. So what is it? It is dextrocardia. But stop there. Watch carefully. Look for the gastric bubble. Look for the fundic bubble. Where is the fundic bubble? The fundic bubble is also on the right side. So not only is the heart placed on the right side, dextrocardia, but the entire abdominal situs is also inverted, and hence the diagnosis here is not just dextrocardia, but it is situs inversus. Yes, so we have discussed this in incidental findings in our respiratory system, right? Videos, right? So along with situs inversus, your examiner has asked you an application based question. It is associated with what? It is associated with, yes, Carter-Jenner syndrome, which is nothing but primary ciliary dyskinesia, which will lead to bronchiectasis, chronic sinusitis, infertility, all of the above. So what is this Carter-Jenner syndrome? So Carter-Jenner syndrome, remember, the basic abnormality is ciliary dyskinesia, dysfunction. So wherever there is a ciliated mucosal epithelium, the cilia won't work well, right? So what happens? The first common finding that we have seen here, where we have anchored this is the anchor finding, is what? It is situs inversus. Correct? Now, everywhere along the respiratory tract, where there is a ciliated epithelium, the cilia won't work. So what will it give rise to? It will give rise to opacification of the sinuses, sinusitis. So this is going to be associated with sinusitis, right? There will be nasal polyp. So this is a functional endoscopy sinus surgery image where you can see a big polyp sitting right in the nasal cavity. So there are going to be nasal polyps. Also, the ciliary epithelium, ciliated epithelium along the airways, bronchi won't work. So what will happen? There will be a retention of secretions, infections, damage to the wall of the bronchi, and such damaged bronchi, because of the damaged wall, they are going to get dilated. Such damaged dilated bronchi are called as what? This will lead to bronchiectasis. So see, the examiner has not asked you about the primary findings seen on the image. The examiner has asked you about its associations, Carter-Jenner syndrome, sinusitis, nasal polyps, bronchiectasis. It may be associated with infertility as well, infertility in males, subfertility in females. So all this combination. Why is it so? Because the underlying abnormality is primary ciliary dyskinesia. This is what is called Carter-Jenner syndrome. Now, this topic of incidentals is almost very commonly asked. And what is asked many times, we've discussed this, is this associations or applications. So let us quickly revise a few of them. This is another incidental finding. See, this vertebra is the C7 vertebra and this is the T1 vertebra. Why? Look at the transverse process of T1. It is traveling upwards and outwards. Look at the transverse process of C7. It is more or less horizontal or it is pointing downwards. And there is a rib-like structure which is articulating with the transverse process of the C7 vertebra. So what is your diagnosis? Your diagnosis here is a cervical rib, and a cervical rib is associated with what? A cervical rib is associated with thoracic outlet syndrome, where the subclavian vessels which are going to go underneath this cervical rib, they may get compressed by this rib and the first rib which lies below these subclavian vessels. So the subclavian vessels are going to get compressed by the cervical rib which is there, bony cervical rib. So there will be ischemia of the ipsilateral upper limb. This is called thoracic outlet syndrome. So next upcoming exam, maybe they give you a cervical rib and ask what is the association with it. So this is thoracic outlet syndrome associated with cervical rib. Now, what do you see in this chest X-ray? You see that the spine has a curve, a lateral curvature of spine. Lateral curvature of spine is called as what? Lateral curvature of spine is called scoliosis. And then they may ask you, how do you measure the curvature of scoliosis? You measure it by drawing lines parallel to the end plates at the terminal end of the curvature. You draw perpendiculars to it. And this angle is used, this measured. This gives you a quantification of the scoliosis so that you can follow up this patient for worsening or improvement. This angle is what is called as the Cobb's angle. So next time they give you a radiograph, this was a NEET question. Next time they give you a radiograph of scoliosis and they ask you what angle will you use? You'll use the Cobb's angle, right? Another question which was asked in one of the FMG exams this time, looking at this radiograph, you can say that this patient has been operated for. Look at this right breast shadow. the left breast shadow is not seen, so the patient has undergone mastectomy. Most common indication for such a radical mastectomy in an adult is going to be CA breast. So by the missing breast shadow on one side, you know that this patient has been operated for breast cancer, right? So coming back to another incidental finding, remember what is very commonly asked with these incidental findings, as we have practiced, is not the finding itself, but its implications and associations. So this we know is situs inversus associated with sinusitis, with nasal polyposis, and with bronchiectasis, right? So this association is what it is: Carter-Jenner syndrome. Yes, so this was the question, the concept of this particular question. Yes. A spotter image from obstetric imaging, USG image taken at around 8 to 10 weeks of gestation is shown here, right? What is the diagnosis? Now, see, the examiner is asking you to identify an anomaly, and this anomaly is diagnosed as early as 8 to 10 weeks. So this anomaly, remember, is the earliest anomaly to be diagnosed. And what is that anomaly? The earliest anomaly to be diagnosed on USG, somewhere around 9 to 10 weeks, is anencephaly, right? Where anencephaly, where the part of the cranium, and as a result, the brain doesn't develop well. So all you see are the two orbits. You can see the orbits there. You can see the intraocular lens, but there's no or deformed brain parenchyma, minimal deformed brain parenchyma seen above it. This appearance has been given us various names. This is called as the frog's eye sign. This is called as the Mickey Mouse sign, frog's eye sign, or Mickey Mouse sign. Various names have been given. So it is a one of the more severe extreme types of neural tube defect. So anencephaly, acrania sequence. Yes. Now let us quickly look at certain obstetric imaging spotters. This is a 3D reconstructed image where you see a big myelomeningocele there. At the terminal end of the spine, there is a spina bifida with a myelomeningocele. So CSF is leaking out, as a result of which the posterior fossa has become very small with the cerebellum wrapping around the brainstem. This is what is called as your banana sign of the cerebellum, as a result of which, right, the ventricles are dilated. And look at the shape of the skull. There is a pinch involving the skull at the frontal end. So the shape of the skull is what is called as the lemon sign. So open spina bifida gives rise to lemon sign, banana spine, and the myelomeningocele sac. What is this combination called as? This is called as Arnold-Chiari type 2 malformation as a result of open spina bifida, typically at the lumbosacral level. Yes. Now look at this classic cardiac imaging. This is a 4-chamber view of the heart where you can see the LV. This is the LA. This is the right atrium. This is the right ventricle. You can see the interventricular septum, interatrial septum very well. So in this particular patient here, this is the RA, this is the RV, this is the LA, this is the LV, and look at the interventricular septum there. There is blood crossing across the septum because there is a VSD there. So this is a muscular part of muscular region, ventricular septal defect, or a VSD detected antenatally. Yes, so this is how a VSD would look like. Now that we have seen a 4-chamber view of the heart, we have identified the chambers. Look at this heart. The LA and LV are so small, no blood flow seen across it on Doppler. This is what is called as the hypoplastic left heart, right? So this is hypoplastic left heart syndrome. So we have seen anencephaly. We have seen certain basic obstetric spotters that could be asked in your upcoming exams. Yes, so this is anencephaly, frog's eye appearance, Mickey Mouse sign, earliest anomaly to be detected at around 9 to 10 weeks, right? The severest form of a neural tube defect. Yes, so this is anencephaly. Now, this is a classic clinical clincher again. Elderly lady, known case of myasthenia gravis is a clue that the examiner is giving you. Presented with fatigue, facial congestion, dilated neck veins, breathlessness. These are all signs of SVC obstruction, right? And you look at a CT, right? This CT image that you see here, you can see this is the ascending aorta, this is the descending aorta, this is the main pulmonary artery dividing into the right and the left divisions, and anterior to the great vessels. In the anterior mediastinum, you see a mass lesion there. If you see a mass in the anterior mediastinum and it is associated with myasthenia gravis, this combination gives you a diagnosis of, we have discussed this multiple times, this is thymoma, right? So of the various mediastinal tumors, right, they could ask you, they asked a thymoma this time and also a teratoma. We are going to discuss that. Now let's quickly revise a few things about anterior mediastinal lesions. How to remember them? For anterior mediastinal lesions, remember most commonly, remember these four T's. One of them we've already seen. What is that? It's a thymoma. Yes. Teratoma. Well, both of them were asked in your recent exam, right? Then lymphoma, terrible lymphoma. Let us call it terrible lymphoma so that it is easier to remember. And something from the neck which could extend down, retrosternal extension of, yes, thyroid, right? So thyroid lesions, right? So these could be the most common anterior mediastinal lesions. The most common of them, remember, is the thymoma. So thymoma is the most common mediastinal lesion. You see a soft tissue mass lesion, right? Usually of homogeneous density in the anterior mediastinum. About thymoma, right? There are few important things that you must know. Thymoma, remember, is the most common mediastinal tumor overall. Remember, thymoma is the most common mediastinal tumor overall. Thymoma is also the most common anterior mediastinal tumor. So overall also in all three compartments of the mediastinum, thymoma is most common. In the anterior mediastinum, it is most common. It is also the most common mediastinal tumor in adults. Most common mediastinal tumor in adults. All right. Now, a very important association of thymoma we have seen. This was a part of your question in this particular exam. And what is that? It is myasthenia gravis. So remember, you see a mediastinal mass, right? With a clinical history of myasthenia gravis, it should clinch the diagnosis of thymoma. You see a mediastinal mass with fat and calcification within it, right? It is usually a teratoma, germ cell tumor, right? Spoiler alert, I've already given you what the next question about mediastinal mass lesion was, right? It was a teratoma because there was fat and calcification within it, right? So that was how clinchers are asked. Let us quickly revise a few things about mediastinal tumors quickly. Most common mediastinal mass lesion overall is a thymoma. Most common anterior mediastinal mass lesion is also thymoma. Yes, we've just discussed that. What is the most common middle mediastinal mass lesion? Well, most common middle mediastinal mass lesion, remember, is a lymph nodal mass. Is a lymph nodal mass, say in lymphoma. If they specifically ask you what is the most common middle mediastinal mass in children, then remember these are called as foregut duplication cysts. Foregut duplication cysts, most commonly you must remember a bronchogenic cyst. Bronchogenic cyst. So, right. So most common middle mediastinal mass lesion in children are usually foregut duplication cyst. Remember bronchogenic cyst. Most common posterior mediastinal mass lesions, remember, are neurogenic tumors. Neurogenic tumors, and because they are neurogenic, they may arise from the spinal cord or the nerve roots. We need to look at their neural extension, and therefore the investigation of choice for posterior mediastinal mass lesions or neurogenic tumors is usually a contrast enhanced MRI. So these are a few factual specifics about mediastinal tumors that I want you to know, right? Now, let us come back to this question. We know that this was an elderly lady with myasthenia gravis, signs of SVC obstruction because of this mass lesion, right? And there was, right, anterior mediastinal mass along with myasthenia gravis. We have just discussed. This has to be thymoma, right? So that was the answer to this particular question. Very, very common tumor. All right, now this is something slightly twisted because of a particular point in the history. Patient presented with chest pain and hoarseness of voice since 1 month. Well, if you look at this CT angiogram image, right, this is an axial section through the aortic arch. Maybe in your exam there was a sagittal reconstructed image, right, but the finding was similar. See, this is the anterior part of the aortic arch. This is the posterior part where it will continue as the descending thoracic aorta. And what you see involving the arch of aorta is a saccular dilatation involving the aorta. Is there an intimal flap within it, within the lumen? No. So this is not dissection, but you see a dilatation, saccular dilatation. So a dilatation of an artery is called as an aneurysm. So this is a saccular aneurysm of the distal aortic arch, right? And this is known to cause hoarseness of voice because if you remember anatomy, the left recurrent laryngeal nerve hooks around the aortic arch, and because there is a dilatation, it is going to compress the recurrent laryngeal nerve, and that is what explains this slightly atypical but specific history of hoarseness of voice. So this is nothing but dilatation of the aorta. This is a saccular aneurysm of the distal aortic arch. So aortic aneurysm, remember, is what? It is an abnormal dilatation. Right? What is abnormal dilatation? How do you diagnose it? You say that the diameter, there is a more than 50% increase in the diameter as compared to what it was at the previous normal segment. Or if you take the absolute size cutoffs, if you want to say that there is an aneurysm or dilatation of the aorta which involves the ascending aorta, then in absolute terms the diameter has to be more than 5 centimeters, the lumen diameter at that point. If you want to diagnose an aortic aneurysm involving the descending aorta, then in absolute terms the diameter has to be more than 4 centimeters. So diameter, right? If you want to diagnose an aneurysm which involves the abdominal aorta, then the in absolute terms the diameter has to be more than 3 centimeters. What is the most common site amongst these? It is usually the abdominal aorta, distal abdominal aorta, in its infrarenal segment, that is after the origin of the renal arteries. This is the most common site of an aortic aneurysm. Now, on a chest X-ray, you can see a widening of the mediastinum there. This is the aortic arch. See how it is dilated, right? This is a very large fusiform dilatation. What we see here on this CT image is another patient where you see a saccular aneurysm. The investigation of choice is a CT angiography. MR angio is done in very selective cases. So CT angiography is the investigation of choice, right? Whereas for any vascular abnormality we have discussed, the gold standard investigation is always invasive catheter, invasive catheter angiography, right? So invasive catheter angiography is going to be the gold standard. So this is all that you need to know about aortic aneurysms, right? A sign which has been described in true as well as pseudo aneurysms, or traditionally it has been associated with pseudo aneurysms, is yin yang sign. What is yin yang sign? It is nothing but you see two colors, red and blue, because of the turbulent flow which is there present within the aneurysm. So yin yang appearance basically suggests extremely turbulent flow within the aneurysms. Traditionally, it has been described with pseudoaneurysms. However, it is also seen with true aortic or popliteal or brachial artery aneurysms. It basically suggests that there is a turbulent flow within that particular portion of the artery, right? Now, when we look at aortic aneurysms, maybe they ask you next time, what are the signs, right, which could suggest impending rupture of the aneurysm, because impending rupture of an aortic aneurysm would be fatal. So we must be aware of what are the signs. Two important signs I'm going to discuss here. One, if you look at the aorta and you see a crescent shaped density like this in the wall of the aorta, it is probably because a blood clot is forming there, and this is what is called as the crescent sign. There is a blood clot there. If there is a leak which develops through the blood clot, the aorta might rupture. So this is a sign of impending rupture. Now, if the shape of the aorta is lost, and look at the aorta here, the aorta has more or less draped over the adjacent vertebral body, losing its normal shape. That is because the aneurysm is spreading, very rapidly. It has draped over the surface of the vertebra, adjacent vertebral body. This is called as the draped aorta sign. So two signs, right, we have discussed here quickly, which could suggest impending rupture of an aortic aneurysm: crescent shaped density in the wall, crescent sign, and loss of normal shape of the aorta, draped aorta sign. Correct. So this could be indicate that this aneurysm is going to rupture. right? So the answer here was aortic aneurysm. Now, this particular question, we're not particularly very sure of what the images were. There are a few students who say that there was a gross histopathology specimen of the brain which was there. Although in the history, they have said that there was a, on radiology, that is MRI, there were some findings. So patient came with history of lethargy, headache, fever, vomiting, so raised ICT, neurological disturbances. Patient was admitted to the hospital, died in a short while. Radiology, so MRI had shown a cystic lesion in the cerebrum invading the ventricles and subarachnoid space. Well, it was this term, invading the ventricles, right, and the subarachnoid space. So it points more towards a tumor. So if you look at this MR image, this is a flare image and this is a post contrast image, right? This is T2 and this is gradient. So gradient is showing you some bleeding within it, blooming, right? A solid cystic mass lesion, and on post contrast you can see that it has a peripheral area of enhancement. Can you see it has pushed the brain to the other side? It has invaded the ventricle subarachnoid space. So this looks like a aggressive tumor, right? So this looks very likely to be a high grade of a high grade of astrocytoma, which is also again evident if you look at the question. The patient died in a short while. High grade tumors, untreated, very poor prognosis. So patient may die in the next few days or weeks, right? Gross histopathology specimen showed, loss of anatomy, right? At this particular site, there are lots of anatomic landmarks. I'm not an expert in this image, I'll admit. And hence, looking at all these signs, looking at the history, right? Looking at the image, looking at the gross histopathology, I feel that the answer here would be a high grade astrocytoma. This does not look like an AV malformation, doesn't look like neurocysticercal granuloma. There's no history of a primary tumor, right, which has been given. So metastasis is also out of question. This is what I think is going to be the most likely answer here. All right. Now let us move on to questions in session 2. There was overlap of topics. So mediastinal tumors, yes, bariums related, GI related topics were asked. There were certain spotters, images without any history. So this was a particular highlight of second session. Well, let us quickly start. So this was either an image or a video where a patient was seen swallowing contrast. And from what students told us, the mouth as well as the oropharynx as well as the proximal esophagus was seen. So I've included both these images here. It was an image based or a video based question. So identify this investigation. What you're seeing here basically is contrast material highlighting the oral cavity, oropharynx, esophagus. So what is this investigation? This is nothing but a barium swallow study. Very simple. Let us quickly look at what are the various barium studies which can be done. So we can start with the barium swallow. Barium swallow, as we've seen in the previous image, it is used basically to look for what? It is used to look for the pharynx, esophagus, and the gastroesophageal junction. So all your diagnosis of, say, esophageal webs, achalasia cardia, CA esophagus, Zenker's diverticulum, esophageal strictures due to alkali or acid ingestion, you'll be able to diagnose on barium swallow studies, right? Diffuse esophageal spasm, right? Zenker's diverticulum, right? All these things can be diagnosed on barium swallow study. Suppose you want to detect stomach and proximal duodenal abnormalities. What do? You do a barium meal study. So basically done to look for stomach and the proximal duodenal. So all your peptic ulcer disease, say gastric cancers, right? So all these things will be detected on barium meal studies. In pediatric age group, we have seen a barium meal study for hypertrophic pyloric stenosis. Yes. Barium meal follow through is done for small bowel evaluation. So for small bowel evaluation, we do barium meal follow through. As you can see, the bowel loops which have a typical feathery appearance. Can you see that? So typical, these are spotter. They may ask you next time, look at this image and identify what these bowel loops are. So bowel loops located in the upper left abdomen with a feathery appearance, right? These are jejunal bowel loops. Whereas if you see these bowel loops, they are located where? In the lower and central abdomen. Do you see any feathery appearance there? No. So what is this called as? This is called as the featureless appearance of ileal bowel loop. So this is the ileum. So these are the ileal loops. So that is how you distinguish between jejunal and ileal loops, location and appearance. We've discussed it here. And now if you want to evaluate conditions of the colon, what study will you do? You do a barium enema where you will be able to assess the colon. So all your CA colon, or say diverticulitis, sawtooth appearance, or ulcerative colitis, Crohn's disease, inflammatory bowel diseases, right? So all these things you'll be able to detect on a barium enema image, right? So this is a spectrum of barium studies, right, which can be done, and the indications and few specific classic appearances that we have seen here. So what are these appearances? Can you tell me? So this is a bird beak sign, right? So typical smooth, elongated, narrowing. So this is what this is. Bird beak sign of what? Achalasia cardia, right? These are normal barium meal studies, normal barium meal follow through studies. We have identified jejunal and ileal loops. And look at this colon, it has lost all its hostile markings. So it looks like what? It looks like a lead pipe. So this is a lead pipe colon seen in inflammatory bowel disease. Which affects the colon? What is that? It is ulcerative colitis. This is ulcerative colitis. So absolute favorite of your examiners, barium and all conventional studies. Okay. So yes, what is this? This was barium swallow study, which was asked in your exams, right? Now this was again a spotter, right? Identify the conditions. If you look at this abdominal radiograph very carefully, what you see here in this image is you see multiple densities, and if you just outline them, right, I'm just going to draw a border around them, and that will give you the diagnosis. What is the diagnosis? This is calcification crossing the midline, crossing the spine on both sides, and taking a typical peculiar shape of pancreas. So what is this? You are looking at a case of chronic calcific pancreatitis, right? Chronic calcific pancreatitis is what this spotter is about. So if you have to quickly revise the spectrum of imaging in pancreatitis, see, clinical clincher, chronic alcoholic, epigastric pain radiating to the back, points towards the pancreas, elevated serum amylase and lipase. You do a contrast on CT, that is the investigation of choice for detection of pancreatitis. You see the pancreas, it's enlarged. Why is it enlarged? Because there's all fluid and inflammation on its surface. So enlarged, heterogeneous appearing, fuzzy margins of the pancreas with a lot of edema around it. So mesenteric edema, right? Ground glass kind of an appearance, right? So if you see here, this is an inflamed acute pancreatitis. So what we do on CT scan when we image pancreatitis is that we use grading systems. Two grading systems I want you to know. Let us quickly revise. The Balthazar grading system and CT severity index. Which one is better? CT severity index is better because it not only takes into account the extent of pancreatic inflammation, but it also takes into account the extent of pancreatic necrosis and also the extra pancreatic findings, and basis of all this it will help us prognosticate. So it will give us the prognosis, right? So that is what we look for when we do a CT. Now this patient, let us follow him up. He was discharged, treated conservatively, responded well, felt better, improved, was discharged. Came back after a few weeks, say 2 months. Fullness in epigastrium, lump was felt. So what happened? There's a complication. There is a fluid-filled cystic area in the region of the pancreas. What is this? This is a complication of acute pancreatitis, which develops in about 6 to 8 weeks. What is this? This is a pancreatic pseudocyst. So pancreatic pseudocyst, right? So typical pancreatic pseudocyst presents after a few weeks, right? Classic spotter. Now this patient was treated, this was drained, the patient developed multiple episodes of acute pancreatitis. Over the next few years, the patient presented with calcification in the parenchyma as well as within the pancreatic calculi, within the pancreatic duct. On a CT, if you look at the pancreas, multiple calcifications seen across the pancreatic parenchyma. So this is what? This is nothing but chronic calcific pancreatitis, and this was the question which was asked in this exam, right? Next time they may ask you what is the investigation of choice. Well, though you can see these calcifications on X-ray as well as CT scan, the investigation of choice, remember, is usually MRCP with secretin stimulation. With secretin stimulation, right? So that is considered to be the investigation of choice. Yes. All right. Now, so what is this image showing us? It is showing us calcification within the pancreas. So this is chronic calcific pancreatitis. It is not a jejunal fecolith, right? It is not a clumped calcification of a fecolith or fecal matter getting calcified. This is not a horseshoe kidney. Horseshoe kidney will be located lower down, right? Though it may not be calcified throughout. This is not mesenteric calcification. This is typically in the shape of the pancreatic parenchyma. This is chronic calcific pancreatitis. Yes. Now, this was again a CNS spotter, right? Now, what you see here, right, let us come to these options. What you see here is basically, this is something that we had discussed in the miscellaneous part. Look at the cerebellum. These are the cerebellar foliae. And at the inferior end of the cerebellum, you're able to see a peg-shaped cerebellar tonsil. So what is this? Is a peg-shaped cerebellar tonsil, and it herniates down into the cervical spinal canal, causes compression of the cervical spinal cord, altered flow of CSF. So what do you see in the spinal cord? Now watch carefully here. Look at the brainstem. This is midbrain, pons, medulla. And what is this inside the cervical spinal cord? You see that it has developed a syrinx. So syringomyelia. Myelia means spinal cord. Syrinx developing within the spinal cord. Syringomyelia. Right. So that is happening because of this peg-shaped cerebellar tonsils herniating down. This was the spotter which was asked in your exams. What is this? This is peg-shaped cerebellar tonsils, Arnold-Chiari type 1. You remember Arnold-Chiari type 2 we've just discussed? Yes, can you remember? Yes, can you tell me? Yes, open spina bifida at the lumbosacral level and intracranially dilated ventricles, shape of skull, lemon sign, shape of the posterior fossa, cerebellum, right? Banana sign, correct? That is Arnold-Chiari type 2. Whereas just peg-shaped cerebellar tonsils is Arnold-Chiari type 1. Let us look at few more CNS spotters. Maybe next time they ask you, right? Arnold-Chiari type 2, yes, we just discussed it. So large lumbar meningomyelocele, right? Dilated ventricles, right? Of course, antenatally you see those lemon sign and banana shape of the posterior fossa. Here you can see colpocephaly, teardrop shape, dilated lateral ventricles. There is corpus callosal dysgenesis, right? Small size posterior fossa, towering cerebellum, right? And herniating tonsils again. Along with all these findings, these are features of Arnold-Chiari type 2 malformation. And look at this large posterior fossa. Remember, when you see a large posterior fossa cyst with widening of the fourth ventricle, see fourth ventricle communicating with this large cyst, widely separated cerebellar hemispheres. Look at how large the size of the posterior fossa is. What is this malformation? This is Dandy-Walker malformation. So Arnold-Chiari 1, peg-shaped tonsils. Arnold-Chiari 2, lot of findings, combination of findings. We've also seen it before, right? And Dandy-Walker, large posterior fossa, cystic malformation. Let us add an edge over it. Let us discuss a few more things. Look at the shape of the, right, midbrain. It looks like a tooth, isn't it? So this is called as the molar tooth sign because of the elongation of the superior cerebellar peduncles. This is what syndrome? This is Joubert syndrome, right? The pronunciation is different. This is Joubert syndrome, molar tooth sign involving the midbrain. Can you see a cleft within the brain there? A cleft within the brain, right? Communicating from the hemispheric surface up to the ventricular system. This is what is called schizencephaly. So it could be open-lipped or closed-lipped. This is a closed lip because two lips of the brain are opposing each other. If they are widely separated, it is called as an open-lip schizencephaly. And this classic appearance at the level of the globus pallidus there is what? It is eye of tiger sign seen in what? Eye of tiger sign seen in Haller-Walden's disease. So maybe next time in your upcoming exam, they ask you one of these and you'll be able to crack it, right? So what is this? This is, as you can see in this image, see corpus callosum is well seen, right? So corpus callosum genesis cannot be there. Dandy Walker malformation, posterior fossa must be large, cystic. There is no such cyst there. So it cannot be Dandy Walker malformation. Vein of Galen, you must see a huge dilated vein at the level of the straight sinus, draining blood. Neonate with congestive cardiac failure, buoy held over the cranium, and a big dilated vein should be vein of Galen. There's nothing like that seen here. So you can definitely see a peg-shaped cellular tonsil herniating down. So what is this? This is nothing but Chiari type 1 malformation. Yes, so we have just discussed this. All right, so MRCP image, magnetic resonance cholangiopancreatography. In the recent few exams, this has been a hot favorite of your INI set as well as NEET-PG examiners. So what does it show you? It shows you the liver, it shows you the gallbladder, and it shows you an extremely dilated common bile duct. Common bile duct. Fusiform dilatation of the common bile duct is a dilatation of the common bile duct. This is what is called as a choledochal cyst. So this was a choledochal cyst, right? Type 1. So choledochal cysts, various types, right? This is how the normal biliary tree is. Right hepatic duct, left hepatic duct, common hepatic duct, gallbladder, cystic duct. Cystic duct and common hepatic duct, they'll fuse to form the common biliary duct, which will open into the second part of duodenum, isn't it? Now, when there is a fusiform dilatation of the common bile duct, this is called type 1 choledochal cyst. This was the question which was asked in this exam. When there is a diverticulum, so what is this classification we are discussing? This is the Todani classification of choledochal cyst. Yes, so if there is a diverticulum like outpouching from the distal part of the common bile duct, this is called as type 2 choledochal cyst. If there is a cystic dilatation in the intramural portion of the common bile duct where it opens into the ampulla, at the ampulla, this is called as choledococele cyst involving the common bile duct. So this cyst-like dilatation at the terminal end of the common bile duct where it opens into the ampulla, this is what is called as the choledococele, right? Type 4 choledochal cysts can be intrahepatic and extrahepatic. Type 4A has both intrahepatic and extrahepatic cysts, whereas type 4B has only extrahepatic cysts. And type 5 is a very peculiar type. We are going to see a spotter. This is what is called as the Carolese disease, where there is saccular dilatation of only the intrahepatic biliary radicals, where a biliary radical is dilated and there is a blood vessel within it. This is called as the central dot sign. So we are going to see that now. So see here, in this image, this was what was asked in your exam. There is a fusiform dilatation of the common bile duct. So this is choledochal cyst type 1, right? If you see in your exam a dilated biliary duct, because there is a black filling defect which is seen within it like this, it will be seen something like this, filling defect within it, then it is a calculus choledocholithiasis which is causing the dilatation there. Another spotter is what is Carolese disease. What is Carolese disease? We have seen there is a dilated intrahepatic biliary radical, and inside it there's a blood vessel. This is what is called as the central dot sign of Carolese disease. Right. So this is what we've quickly revised about choledochal cysts. So we have seen this. This is a fusiform dilatation of the common bile duct, and this is type 1 choledochal cyst. That is the answer to this particular question. A lot of hepatobiliary questions, ERCP, MRCP have been asked in the last couple of years. So very, very high yield topic for your upcoming exams as well. Yes, now this is a very tricky question. This was a CT image. See, diagnosis based on CT. No history available, right? So you just look at the image. Now, what do you see in this image? This is a CT of the abdomen. Region, organ, lesion. Do you remember? Region, CT abdomen. Next is region, organ. What is the organ which is involved? Now, where are we? We are at the level of the mid abdomen. So you can see the lower thoracic or the upper lumbar vertebra here. You are able to see all the bowel loops here. I can see an organ here. This is the right kidney. Looks normal. Can I see the left kidney? Oh, it's looking abnormal. It's very large. So the organ involved is the left kidney. Region, organ, lesion. Remember, we have discussed it in the CT interpretation module. So what is the lesion? The lesion is appearing hypodense, isn't it? It is appearing slightly dark. Why is it hypodense? Because it is all fluid filled. See, this is air. This is appearing extremely hypodense, jet black. This is air, but this appearance is relatively gray, hypodense, dark appearance. This is because it is full of fluid. So in the left kidney, there is a lesion which is full of fluid. The first thing that comes to my mind is a cyst, multiple such cysts. You can see some fluid filled areas here, 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 here. Am I looking at a case of polycystic kidney, right? You could think so, and then you see one option, polycystic kidney. You mark that as an answer, but unfortunately, it is wrong. So don't rush to this question. Why? Because this is an adult patient, right? And so if it is a polycystic kidney, we must be looking at the autosomal dominant type of polycystic kidney disease, where the rule is that the involvement is always bilateral. And here it is not bilateral, it is unilateral. And hence polycystic kidney is not the answer. Could it be a single large cyst? No, I can see one component here, 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 here. So it cannot be a single cyst. Is it a tumor? There is no enhancement. They have given you a non-contrast image here. Maybe in the exam it was a post-contrast image, but there is no enhancement. What is left is PUG obstruction. How can this be PUG obstruction? Well, it could be if you look at the kidney like this, and this is the pelvic system. Where is the pelviureteric junction? It's here. Suppose there is an obstruction of the pelviureteric junction here. The first thing that happens is that the renal pelvis gets dilated. It gets dilated to a very large extent. So if this is the kidney, there is an obstruction at the pelviureteric junction. The renal pelvis gets extremely dilated. It sometimes gets so dilated that it can even cross the midline because it is obstructed. And then as a reaction to that, the calyces also get dilated like this. So if you look at this appearance here, in this image, what you're able to see here, this outline that I'm drawing here is the massively dilated renal pelvis. Whereas, as a result of the pelvis being obstructed and so massively dilated, these are the renal calyceal dilatation. This is the calyceal dilatation which has also happened. The renal pelvis is dilated disproportionately to a greater degree. This is in fact the clincher of the condition of pelviureteric junction obstruction. As I said, right after giving so much of thought to it, we were able to detect it. But the next time if you're asked a question on pelviureteric junction obstruction, you should not get it wrong, right? This was a slightly tricky one in your exam. So yes, so this is what we just discussed. If the obstruction is over here at this site, what is going to happen to this renal pelvis? It is going to get dilated massively. It may even cross the midline, and then the calyces would also get dilated, and that is how this appearance would present. So we've already discussed this. So it may be detected incidentally, it may be congenital or acquired, sometimes presents with pain in lumbar region. Can you see here again in this eye view image? The renal pelvis is more massively dilated in comparison to the calyces which are dilated. So this is again a typical feature of pelviureteric junction obstruction, because there is an obstruction here. The urine is not passing distally, so the ureter is not opacified, but the calyceal system is dilated. More so, the renal pelvis is dilated. So this is pelviureteric junction obstruction. If you look at the graphics, they are normal right-sided calyceal system. Can you see that? And the massively dilated left-sided pelvis and calyces. So this is PUG obstruction causing hydronephrosis. There's something that I want you to know, which is called diuretic renography. Sometimes if the pelvis is just located outside the kidney, it can appear prominent. So what do? We give a diuretic followed by a intravenous urography. So this, what will happen in pelviureteric junction obstruction, because there is a true obstruction here. In PUG obstruction, there will be a further dilatation of the system, because the kidney is going to excrete all that, urine. You have injected contrast, but there is a true obstruction, it cannot go pass down. So there will be a further dilatation of the system. Whereas if there is just an extra renal pelvis without obstruction, what it will do, once you give diuretic, it will simply give rise to the washout of the contrast, and there's no further dilatation which will be seen. So that is how diuretic renography was used in olden days to distinguish between true PUG obstruction. versus extrarenal pelvis, but now we have excellent imaging modalities like CT urography to do that. All right. So therefore, as a result of a lot of discussion that we have had saying that this is the dilated renal pelvis and these are the renal calyces, we now know that the best answer to this particular question is PUJ obstruction, right? So that was the basis of arriving to this particular answer. So match the following correctly as shown in the image. A, B, C, D, 4 marks, right? 4 pointers which were placed on the image. There were various options saying A is what, B is what, correct? So let us quickly look at the CT anatomy of the thorax. If you start from a top level where you are able to see the clavicles which are reaching the sternum almost. When you start, look at the mediastinal great vessels. This great vessel on the right, so this is right, this is left, is the superior vena cava. Then you have the three great arterial branches that arise from the aortic arch. So you have the brachiocephalic artery, which will divide now into the right subclavian and the right common carotid. Then you have the left common carotid, and you have the left subclavian, right? Then you go to a slightly lower down level, right? You come to the area of the aortic arch. This was where the question was asked. You can see the sternum anteriorly. So this is always right. This is left, remember. Again, this largest blood vessel is the SVC. Now you are able to see the aortic arch, right, which travels from right anterior to the left posterior, and this will continue as the descending thoracic aorta as you go inferiorly, right? And then you see two air-filled, right, structures here. One has a taut oval round lumen, and the second one is like a crescent because it is like a sandwiched behind the front one or the middle one. So what is this? This is the trachea. It is maintaining its shape because of the tracheal cartilaginous rings in the tracheal wall, whereas the esophagus has no such cartilage in its wall, so it is sort of collapsed. It is located behind the trachea, so this is the esophagus, right? This was what was asked in the exam. If you go to a section further down, now we know that this is the ascending aorta anteriorly. Just to the right at it, the rightmost vessel is again the SVC. It is going to open into the right atrium now, right? So this is right, this is left, ascending aorta. Here you have the descending aorta, right? This is the main pulmonary artery which is going to divide into the right and the left pulmonary artery branches. Now here if you see there are two bronchi, again the shape is maintained. See, this is the right main bronchus, left main bronchus, and this is where you should be able to see the esophagus. There you can see the thoracic vertebra behind it, ribs in oblique cross sections, and the sternum anterior. Okay, now we come down to the chamber great or the cardiac chamber level. This is the interventricular septum. So this is right, this is left, this is going to be the right atrium, right ventricle, the left atrium, left ventricle, and behind the heart you see a large great vessel. This is the descending aorta or the descending thoracic aorta there. So now that we have seen a quick review of the CT thorax anatomy, now can you tell me what is A, B, C, and D? Let us quickly revise. We have just seen it. What is this? What is A? A is superior vena cava. What is B? B is aortic arch, correct? What is C? C is, look at the shape because of the cartilaginous rings. So C is the trachea. And what is D? Right? D is, look at the shape there, right? It's more or less, squeezed into the behind the trachea. So that is the esophagus. Yes. So this would be the answer to this particular question. There are various options with a lot of permutations and combinations. I think this is what is the anatomic landmark identification in this particular image. Yes. So 35-year-old female presented with fever for 5 days and there are no signs of meningitis. MRI with diffusion weighted imaging. So diffusion weighted imaging is showing a bright image, right? Bright hyperintense appearance. So that is telling me that there is a restricted diffusion. And on a post contrast image, there is a peripheral hyperintense rim. So there is a ring enhancement around it. So a ring enhancing lesion within the brain, infective etiology, which shows diffusion restriction, is suggestive of a cerebral abscess, remember. So we had discussed this. Now see here, this was also asked recently a few years back in a NEET-PG exam. So young or middle-aged patient, sinusitis or chronic ear discharge, this history was not here, but there was a history of fever, headache. Yes, altered sensorium could be there. On imaging, right, if there is otitis media, the infection spreads from there. So it could be temporal ring enhancing lesion, right? There are signs of meningitis, right, which were not there in our patient, but there was a ring enhancing lesion here. And if this ring enhancing lesion on diffusion weighted imaging appears bright, so then that suggests that there is a restricted diffusion. Then again, all this together points to a diagnosis of brain abscess. What of particular in our question in this exam was there was a combination of restricted diffusion on DWI and a ring enhancing lesion which was given. So restricted diffusion on DWI and a ring enhancing infective lesion is suggestive of brain abscess. But remember, there are various conditions which could give rise to restricted diffusion on DWI. So restricted diffusion on DWI and a ring enhancing appearance or ring enhancing lesion on post contrast suggests a diagnosis of brain abscess. Remember. All right, it is this combination which was asked in your exam. Now, let us quickly discuss what other conditions can give rise to restricted diffusion on DWI. Well, we have studied something in stroke imaging. Do you remember? Yes, an acute infarct. An acute infarct can give rise to restricted diffusion on DWI, but it will never show a ring enhancement pattern, right? So therefore, this combination won't give rise to a diagnosis of acute infarct, right? What else can show restricted diffusion on DWI? There are certain cysts within the brain. These are called as epidermoid cysts. Epidermoid cysts, which can sometimes give rise to restricted diffusion on DWI. Occasionally, very rarely, say subacute bleeds. Subacute bleeds within the brain, especially in cases of diffuse axonal injury, can occasionally give rise to restricted diffusion. Occasionally, conditions like lymphomas can give rise to restricted diffusion on DWI. But the peculiar combination of a restricted diffusion and a ring enhancing lesion is suggestive of brain abscess. Remember, so again, this combination of restricted diffusion, bright appearance on DWI, and a ring enhancement pattern on post contrast study, we know this combination is suggestive of cerebral abscess. Yes, brain abscess, correct. Now, this is typical. So, I have multiple times we have discussed if it is one tumor, brain tumor, which is going to be the most common one to be asked in your exams, it is going to be this one, right? A child presents with visual disturbances and headache. Why? Because there is a lesion, right, in the suprasellar cistern. It is compressing on the optic chiasma, causing bitemporal hemianopia. Maybe next time they ask you this. On imaging, he was found to have a suprasellar lesion. Biopsy and examination, the tumor exuded black motor oil. Oh, this is new. This can also be called as machinery oil appearance, right? That is the aspirate from this tumor, right? So the CT image is shown here. Remember, a calcified. This is what we had discussed in our videos. Calcified cystic solid tumor. Cystic solid tumor in a child, where in the suprasellar region, right? So a calcified cystic solid region in a child in the suprasellar region is always a craniopharyngioma. Remember, right? So this is the clincher for craniopharyngioma. If you look at the suprasellar region, one tumor that we have just discussed is a craniopharyngioma, right? We have done this in our CNS videos where we have looked at a location and quickly discussed few differentials. In adults, this typically, has a specific tumor here. What is that tumor? It is a pituitary adenoma. So pituitary adenoma, certain gliomas, right, meningiomas can also present over here. But as far as your exams are concerned, remember craniopharyngioma and pituitary adenoma. Craniopharyngioma is seen in children, pituitary adenoma is seen in adults. So let's quickly have a look. Craniopharyngioma, very typical. We have seen a calcified tumor, right? Cystic solid tumor in a child in the suprasellar region. That is the area that we are discussing right now. This is craniopharyngioma. And because it is a cystic, there's a cystic part, when it is aspirated, it gives rise to plaque motor oil or machinery oil like aspiration from there. In adults, so pituitary macroadenoma, right, typically is seen in adults. Macro because it is more than 10 mm in size, and because the central part of the tumor as it comes out of the cella is constricted by the diaphragm cellae, it gives rise to the typical snowman appearance or figure of 8 appearance, because this central part is constricted by the diaphragma cellae, that is the dural fold there. So this is what is your figure of 8 or snowman appearance, right, in a cellar supracellar mass seen in adults. Microadenomas are very small, they are less than 10 mm in size, and they usually enhance less as compared to the adjacent normal pituitary gland, as you can see there. Therefore, they are appearing hypointense or dark, and a specific technique of MRI is used to diagnose it. What is that? It is dynamic contrast enhanced MRI, where rapid image acquisition is done after injection of contrast, is used to diagnose microadenomas, small, less than 10 mm in size. Right. So this tumor, remember, a calcified cystic solid mass in children in the suprasellar areas has to be always a craniopharyngioma. Multiple times that we have discussed this in our discussion. All right. Now, this is a little bit tricky. Let us try to crack this. Child presented with seizure, subsided with midazolam. Why was there a seizure? There must be a focus to it, right? Why did it arise? Lumbar puncture study was done to rule out infection, meningitis, right? Normal. Blood investigations, normal. No pyogenic infection, no systemic disturbance. MRI was done. And on MRI, what do you see here? Now, if you look at this MRI, this is T2. This is same, but CSF is suppressed, so this is flare. This is gradient to look for calcification or hemorrhage, and this is post contrast. Look at the striking appearance on post contrast. What do you see? You see some ring like enhancement there. Can you see that? So this is a ring enhancing lesion on post contrast study. Look at T2 and flare. Can you see all this bright appearance around it? It is edema. So edema around it, and this was the focus why the child had a seizure. So ring enhancing lesions, the most common entity that I'm thinking of right now is some infection within the brain parenchyma, right? Because there's no sign of tumor, it is a child, right? But lumbar puncture was normal, so maybe infection which is just limited to the brain, right? Like encephalitis, focal, possible. It has not yet involved the meninges. Blood was normal. So what are the most common infections that you could think? The child does not have fever. It could not be abscess. Two most common infections I'm thinking of is tuberculoma within the brain parenchyma or a neurocysticercosis granuloma. There's no tubercular meningitis. Why? Because lumbar puncture study was normal. So now I'm basically trying to distinguish between a tuberculoma and a neurocysticercal granuloma. Will PET scan help? No, it will not. Any inflammation because of the high metabolism may show increased uptake there. It will not help. More so, PET scan not very useful in brain lesions, right? So gene expert study of CSF will not help because lumbar puncture is absolutely normal. Had I seen something there, then I would have, followed it up by doing a gene expert study of the CSF. It will not help. Ocular B scan, right? Ocular B scan is where we try to look inside the orbit using ultrasound, right? B mode ultrasound. It will not help because neither in tuberculoma nor in neurocysticercosis we get frequent ocular involvement. Can MR spectroscopy help? Let us try to find out the answer to this particular question. Neurocysticercosis versus tuberculoma, classic sign, right, is a scolex seen within the parasite. You see a ring enhancing lesion and an eccentric dot within it. This dot is nothing but the scolex. There were a few students who said that there was indeed a scolex which was seen in the image, whereas many students say that it was just a plain ring enhancing lesion. If we would have seen these colex, then it would clinch the diagnosis of neurocysticercosis. So that would have absolutely clinched it, but it was not the case, not very clear. This, seeing a dot within it, is given a name. This is what is called as a cyst with a dot sign, or target sign, or dot in a hole sign. So fancy names given to this particular appearance of these colex in neurocysticercosis. Now, about neurocysticercosis, I want you to know something which is called as Escobar's staging, pathological as well as imaging staging. Earliest acute stage is called vesicular stage. Just imagine, look at the story of neurocysticercosis. The cyst has just happened, right? The body has not reacted to it, and hence there is no edema, inflammation, or contrast enhancement. As the cyst degenerates in the early subacute stage, the parasitic antigens, go into the brain parenchyma. These are foreign antigens. Body reacts to it. There is a strong inflammatory response, and therefore, in the next colloidal vesicular stage, early subacute stage, there is maximum edema, inflammation, enhancement. As the body has launched an immune response, right, the body tries to limit the infection. This is the late subacute stage or granular nodular stage, where there is a decreasing trend of edema, inflammation, enhancement. Ultimately, the body wins, the immune system wins, the infection is controlled, the parasite dies. Over many years, it gets calcified. It appears as a calcific speck or a dot within the brain. This is the chronic nodular calcified stage of neurocysticercosis, which is characterized by a dead calcified parasite, no inflammation. So there is no edema, inflammation, or contrast enhancement, which is there. Right now, if you look at this child now, we see that there is a differential of tuberculoma versus neurocysticercosis. We have seen a ring enhancing lesion. There is no meningitis which is there. PET scan will not help. Lumbar puncture is normal. So gene expert study of CSF would not help. Ocular B scan would not help. Will MR spectroscopy help? Well, what is MR spectroscopy? MR spectroscopy is a specialized application of MRI which helps us to know what is the biochemical composition of the brain tissue. Now, this is a normal MR spectrum, normal spectrum of MR of the normal brain, so which the normal brain metabolite, which is Na, it has the highest peak, remember. This lipid peak or a lactate peak is considered to be a marker of infection. So it will increase in infections. Therefore, normally you see a very low level of lipid or lactate. Now, all these amino acids, choline, creatine, myoinositol, they are specific for certain conditions. So we'll see that. So this is our normal spectrum of MR spectroscopy looks like, especially a marker called choline. Now, another one thing I'm going to add here. Choline is a marker which is increased in brain tumors. So, if I see that there is a condition where the normal brain marker, that is N-acetyl aspartate, is decreased, but choline is increased, it will give me a possibility of tumor. Got it? Na, that is the normal brain metabolite, is decreased, but lipid lactate is increased. It will give me an indication towards necrotic infection, mainly tuberculosis, right? And certain specific conditions, certain specific amino acids are increased. Now, if I do an MR spectroscopy in a case of tuberculosis, look at the Na peak here, somewhere around 2. Look at the Na peak at somewhere around 2. It is severely decreased. So normal brain tissue has been destroyed. Look at the lipid peak at around 1.3. Normally it is so low, but the lipid peak at around 1.3 here is very significantly elevated. So this is the lipid peak which is elevated. I told you this will point towards a necrotic infection, and this is the classic pattern of tuberculous infection. This is the spectrum of tuberculosis infection on MR spectroscopy. Also, certain amino acids are also increased here, right? So this is how the MR spectroscopy pattern looks like, right, in tuberculous infection. How does it look like in neurocysticercosis? In neurocysticercosis, almost all the metabolites within the brain are extremely low, remember. So in tuberculosis, NA, normal brain metabolite, will fall, lipid lactate peak will be high, right? Amino acids will be elevated. But what will happen on MR spectroscopy in neurocysticercosis? Almost all the brain metabolites are very low. So tell me now, can MR spectroscopy be used to distinguish between neurocysticercosis and tuberculosis? The answer is yes. It is one of the tools which is used. And therefore, when we are faced with this kind of a clinical situation where we know that there is a focus for seizure, it looks infective, there is no meningitis, CSF is normal, so other investigations like gene expert won't help. Can we use MR spectroscopy to help and distinguish between neurocysticercosis versus a tuberculoma of the brain? The answer is yes. In neurocysticercosis, you'll get diffusely low metabolites within the brain, whereas in tuberculosis, you will get increased lipid peak, decreased Na, and certain specific amino acids will be increased. And that is how MR spectroscopy will help us distinguish between neurocysticercosis and tuberculoma. Tricky question again, but this is what is the answer to this particular question. Yes. Now, friends, do you realize that many questions in this exam were based on your second order thinking? It was not just about the looking at the image and diagnosing it, because as you see here, the examiner did not ask you about this button battery, but the examiner wanted you to know about your double ring sign. So maybe next time the examiner will ask you about the anode cathode extras that we have discussed. The examiner did not want you to diagnose SAH, but the examiner wanted you to know a little bit about berry aneurysms, much beyond what is apparent at the first glance, isn't it? This is an example of second order thinking. The examiner did not want you to just detect dextrocardia and situs inversus. The examiner wanted you to know about Carter-Jenner syndrome and its components. The examiner did not just want you to pick up an anterior mediastinal mass and say that it is thymoma. The examiner wanted you to know its association with myasthenia gravis. So if you see, not just in life, but for you, the most important upcoming exam, that is the NEET-PG exam, all these exams, what they have started asking you more and more and more is not questions based on first order thinking, not what is obvious, but something related to it, something around it, something associated with it. And this is an example of second order thinking that I want you to practice, not just in your day-to-day practice, in your day-to-day studies as well. So if you would look at the NEET-PG exam here, remember, not only have we discussed these related things, we have discussed multiple imaging concepts. We have discussed about the cathode anode part of the button battery. We have discussed about how to image SAH. We have discussed about the various mediastinal tumors and why MRI is the investigation of choice for neurogenic tumors, posterior mediastinal tumors, because we want to know the neurological extension. So such many concepts we have discussed, and these are just examples of second order thinking. Well, we have discussed clinical based clinchers, right? Multiple clinchers, right, that we continue to discuss. Child presence at birth with bilious vomiting is duodenal atresia. Child presence after a few weeks with non-bilious vomiting is pyloric stenosis. So multiple such clinical clinchers we have discussed. And what we are going to follow now, throughout our, not only throughout our basic videos, but all these sessions, as and when we go through these things, is we are going to follow an integrated approach. My aim here is not to just enumerate the questions and tell you what the answers are, but my aim here is to prepare you for the upcoming exams, so that even if in the exam you get a question which you on a topic which you've not discussed before, which we've not seen before, right? Still using all these concepts, clinical clinchers, integrated approach, various tips and tricks and clues that we've discussed, my students should be able to crack those particular questions, get that dream rank and your dream postgraduate seat of your choice. So that is what we are going to do here together. All the very best. Let's rock radiology. Thank you.